Hello, everyone. My name is Shannon Jordan. I'm a program analyst and serve as the engagement lead for the VHA Office of Health Equity. I'm happy that you've joined us today. We have a great presentation planned for you. First, I'd like to share a little bit about the Office of Health Equity for those who are new to this cyber seminar series, Focus on Health Equity in Action. For those who are returning, thank you. So, a little bit about the Office of Health Equity. It was established in 2012 and currently under the direction of our Executive Director, Dr. Ernest Moy. Um, the office is also referred to as OHE. OHE's vision is to champion the advancement of health equity and reduction of health disparities and to ensure appropriate individualized care for each veteran. OHE collaborates with the Health Equity Coalition to establish operational plans and achieve goals guided by a health equity action plan to achieve health equity for veterans. The HEAP plans and goals are updated annually, and they're focused around 5 aims, including awareness, leadership, health outcomes, cultural competency and diversity, and data research and evaluation. Here we have a screenshot of our homepage. So I encourage everyone to visit the website um, to learn more about the office. We will also post in the chat a link to our SharePoint where there's additional great resources. Now I'd like to introduce today's presenters who will share some important information with you on social determinants of health and ICD-10 coding. Dr. Alicia Cohen is core investigator at the VA Providence Healthcare System Center for Innovation in Long-Term Services and Supports, an assistant professor of family medicine at the Alfred Medical School of Brown University, and an assistant professor of health services policy and practice at the Brown University School of Public Health. Her research aims to understand and improve patient, community, health system, and structural level processes to identify and address social determinants of health and clinical settings, with a particular focus on food insecurity. As a VA Career Development Awardee, she is developing and piloting a VHA community partnered intervention to optimize screening and referral processes for connecting veterans experiencing food insecurity to relevant VA and community resources. She also co-leads the VA Office of Health Equity funded Social Risk Screener and Referral Initiative, ACORN. Dr. Cohen practices primary care at the VA Providence Healthcare System's Homeless Pact and Women's Health Pact. Ms. Maria Bruton is certified as a medical coder by the American Association of Professional Coders. Ms. Bruton started her career in healthcare as a certified medical assistant working for Planned Parenthood in Fort Worth, Texas in 1992. She then transitioned to the administrative side of healthcare through working as a coding appeals auditor and appeals specialist for Texas Oncology, PA Baylor Sammons Cancer Center for 12 years. During this time, she was a medical coding instructor with the Concord Career College and Remington College for 14 years before starting her career with the Dallas VA Medical Center. She is currently a health information management specialist and supervisor at the Dallas VAMC. Her responsibilities include working with Dallas VAMC's Chief of Staff Office to help promote clinical documentation integrity and working closely on inpatient CDI efforts with clinical service chiefs. Dr. Dina Hooshyar started her medical career as an infectious disease physician and was an epidemic intelligence service officer at the Centers for Disease Control and Prevention. During this time, she served in the U.S. Public Health Service Commission Corps. She then became a psychiatrist. Prior to becoming the National Center on Homelessness Among Veterans Director in March 2019, she was the physician advisor at the Dallas VA Medical Center, where her responsibilities included clinical documentation improvement. She is also an associate professor at the University of Texas Southwestern Medical Center in Dallas, Texas. Her research interests include homeless prevention and societal reintegration of veteran homeless population. So as you can tell, we have a great panel of presenters today, and I'd like to turn it over to them at this time.
Thank you so much, Shannon. And thank you all for having us here today. We are, and I'm sorry, just trying to get the controls to work. Here we go. We are very excited to talk with you all today about the WHO's greatest ICD-10 hits for fiscal year 2022, social determinants of health. So just to let you know, we have no disclosures. And our objectives for today's session are first, to develop an understanding of social determinants of health and why we should address them in healthcare settings. To discuss how clinical documentation and coding can capture social determinants and why this is important. And then finally, to learn about a current initiative within VHA to better identify and address social determinants of health. So just to start with some definitions, this definition is from the World Health Organization. Social determinants of health are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social norms, social policies, and political systems. I really like this definition and the full definition, because I feel like often we kind of see the first sentence of that, but not the full definition, because it really emphasizes both the individual level and broader structural and systemic factors driving social determinants of health. And this is just a figure that visually depicts some of these social determinants, which can be major contributors to increases in acute care utilization, healthcare costs, and premature morbidity and mortality. And so as you can see, there's, we'll be talking a lot more about these, but social determinants related to economic stability, neighborhood and physical environment, education, food access, community and social context, and then also looking at social determinants within the healthcare system as well. So I also just quickly want to review some additional terminology. We've spoken a bit about the term social determinants. There's some other terms that both in this presentation and elsewhere you may hear. Social risk factors, by which we mean individual level adverse social determinants of health or adverse social conditions associated with poor health, such as low educational level, food insecurity, or housing instability. And then we'll also talk about social needs, which is really more of a patient-centered concept that incorporates a person's perception of his or her own health-related risks, and recognizing that when we're screening, we're screening for the social risks, but it's really up to patients to tell us what their needs are. And distinguishing between social risks and social needs emphasizes the patient's role in identifying and prioritizing social interventions. So we may identify several risk factors on a screening instrument, like housing and food insecurity or low educational attainment, but these are just screening instruments and they're not diagnostic. And additionally, a patient may identify and prioritize certain needs or assistance over others. So it's really critical to not only screen patients, but also to have a discussion with them about their needs and their priorities. So now that we've reviewed definitions, I want to talk a bit about why we should address social determinants, risk factors, and needs in healthcare settings. So although 95% of US healthcare resources are spent on direct medical services, up to 80% of modifiable variation in health outcomes are rooted in social and economic determinants, health behaviors, or the physical environment. And only 20% are attributable to clinical care. So in a recent QI initiative that we will be talking about a bit later in the session, the QI initiative ACORN, this was a pilot at 2 primary care clinics in Vision 1 40% of veterans screened positive for at least one social risk. 29% screened positive for social isolation, and these numbers were actually pre-COVID, so the social isolation and actually all of the numbers have gone up since then. 9% endorsed housing instability, 7% endorsed utility insecurity, so having difficulty paying for their utilities or potentially even having their utilities already shut off. And then 1 in 5 endorsed at least some form of financial hardship, including housing instability, food insecurity, or utility insecurities. So addressing social risks is a central feature of efforts to improve health and health equity, and clinical documentation matters. These data were pulled from clinical notes, and the only reason we know that veterans were experiencing these social risks is because someone took the time first to ask, and then two, to document the reported needs, which will be the focus of much of what we're discussing today. And so with that, I will turn things over to Dr. Hooshyar.
Thank you, Alicia, for laying the foundation for our presentation today, which is healthcare systems should address social determinants of health. And thanks. And we're now going to go to the questions that you alluded to, which is what do clinical documentation and coding have to do with identifying social determinants of health? And why is it important for clinical documentation and coding to capture social determinants of health? Full disclosure, clinical documentation and coding are not the reasons why I became a physician. If someone had told me when I was a young physician that in the future I would be educating and trying to motivate clinicians, coders, administrators, researchers, policymakers about the great significance of clinical documentation and coding, I would have either thought the person didn't know me or thought, what did I do terribly wrong in my career decisions to end up in that role? And actually by young, I mean around 5 years ago when I met Maria in my role as a physician advisor, were my responsibilities, including assisting other clinicians to improve their clinical documentation. But more to come on that story. Let's first talk about the story of the International Classification of Diseases, affectionately known as ICD. I'm not a medical historian, but the internet tells me that in 1676, Antonio van Leeuwenhoek was the first person to see bacteria using a microscope. But it wasn't until 1928 that Alexander Fleming discovered penicillin, the first true antibiotic. I remind us of these facts to provide the historical context of ICD's origin story. Science and medicine in the West were just blossoming in terms of classifying diseases systematically. With this understanding, then came the ability to classify causes of death. By late 1800s or early 1900s, there was an established categorization of causes of death that many countries used. In 1923, the League of Nations, which was an international organization created after World War I to provide a forum for resolving international disputes and was a precursor to the United Nations, became interested in vital statistics. However, with World War II, the League of Nations dismantled its offices, but the idea of vital statistics and categorizations of causes of death remained. In 1944, the United States Public Health Service and United States Bureau of Census expanded diagnosis to capture morbidity, not just mortality. In 1945, when diplomats met to form the United Nations, one of the things they discussed was setting up a global health organization called World Health Organization. The World Health Organization Constitution guides member states in compiling morbidity, mortality statistics in accordance with what we know now as the ICD. As we reflect on the origin history of ICD, we can see that it started from the need to identify the causes of death and then expanded to identify causes of morbidity, but drivers were not how do social determinants of health impact mortality and morbidity. This concept formally entered into discussions in 2003 when the World Health Organization provided a list of social determinants of health, and then in 2008 when the World Health Organization Commission on Social Determinants of Health published a report entitled Closing the Gap in a Generation, which included connecting social determinants of health to bridging gaps in the healthcare system. Knowing this perspective of the ICD, let's get back to the question, why is it important for clinical documentation and coding to capture determinants of health? What clinicians document in clinical notes gets translated into ICD codes either by the treating clinician or a coder. These codes then influence a whole host of outcomes, including individual patient-level care. For example, a patient presents with a urinary tract infection or UTI and sepsis, which occurs when the body has an inflammatory response to bacteria, for example, in the bloodstream. How the clinician opts to document and then code the diagnosis for this episode of care, whether it is UTI or sepsis, will influence the clinical approach that other clinicians will provide this patient due to the severity of illness is different between a UTI and sepsis. Clinical documentation and hence ICD codes that generate from clinical documentation also impact hospital level interventions. In the VA, we utilize, for example, SAIL to guide us on what clinical processes could be enhanced. The information that feeds SAILs comes from ICD codes. For example, for the patient who presents with a UTI and sepsis and is subsequently hospitalized, the expected length of stay would be shorter for UTI as compared to sepsis. Thus, a longer hospital length of stay as compared to the expected length of stay might have nothing to do with the effectiveness of the care we're providing, but rather how we as clinicians and coders are capturing the care that we're providing. In this example, having the admitting diagnosis of UTI would erroneously give a shorter expected length of stay because the patient's really being admitted for sepsis management. Same concepts apply to payment, hospital resources, health organizations' reputations, patients' perceptions, research, and policy. What all these people and entities see and hence interpret and act upon is not all the details that clinicians write in their clinical notes, but rather the ICD codes that the documentation supports. So back to the story of how I met Maria. My job as a physician advisor was to enlighten clinicians about why documenting in a manner that clearly supports the diagnosis is important. From my perspective, Maria's job was to enlighten me about why documenting in a manner that clearly supports the diagnosis is important. I remember telling her that if she can't convince me, there's no way that I will be able to convince my fellow clinicians. Our conversation's basic themes were, I don't understand why the ICD doesn't capture the primary reason that a significant portion of patients present for healthcare, that is social determinants of health. For example, a patient doesn't have the money to pay for the co-payment needed to purchase their blood pressure medication, hence runs out of the blood pressure medication, and then presents for care with high blood pressure. Even if the clinical documentation links the reason for high blood pressure is lack of funds to purchase antihypertensive medication, the ICD code for the diagnosis, primary diagnosis, will still be high blood pressure. This coding practice wasn't cool to me because of the impact ICD codes have on all aspects of healthcare. Maria's response to me was always, take it to the WHO. And the first time she told me that, I had a couple of automatic thoughts, which are presented on the slide. And one of them was the image of the rock band. The other was their song, Who Are You? Who? And then the other was Maria has some special jokes that as a physician, I simply don't get. And now I'm going to give the mic, so to speak, to Maria. Maria, are you on?
Still muted?
I think Maria, somebody said you're muted.
Sorry, so you are still muted. If you want to just tap on that unmute button on your WebEx window. Yep, you're unmuted now.
Okay. Can you hear me?
Yes, perfect. Thank you.
Okay. Sorry about that. Okay. Yes, I did tell her to take it to the WHO. as far as getting changes made to diagnosis codes and things of that nature. So I'm going through and telling you who maintains the ICD-10 CM here in the United States. First, the World Health Organization, and, along with CMS and CDC, the National Center for Health Statistics. This is a globally used diagnostic tool for epidemiology and health management and clinical purposes. The ICD is maintained by the World Health Organization, which is directing and coordinating the coordinating authority for health within the United Nations system. ICD is originally designed as a healthcare classification system, providing a system of diagnostic codes for classifying diseases, including nuanced classifications of wide variety of signs and symptoms, abnormal findings, complaints, social circumstances, and external causes for injury or diseases. However, the adoption of ICD was slow in the United States. Since 1979, the U.S. has required ICD-9 CM for Medicare and Medicaid claims, and most of the rest of the American medical industry followed suit. The one thing that we have here in the United States is the ICD Coordination and Maintenance Committee. Effective October 1st, 2015, ICD-10 CM and PCS replaced ICD-9 as the HIPAA-adopted code set for medical diagnoses and inpatient acute care procedures. As of March 19, 2014, ICD-9 Coordination and Maintenance Committee was renamed the ICD Coordination and Maintenance Committee. A representative from the National Center for Health Statistics, NCHS, and one from the Centers for Medicare and Medicaid Services, CMS, co-chair ICD-10 Coordination and Maintenance Committee. Responsibility for the maintenance of ICD-10 is shared between those two agencies, with NCHS having lead responsibility for the ICD-10 CM for diagnosis, and CMS having lead responsibility for the ICD-10 PCS for inpatient acute care procedures. The ICD-10 Coordination Committee is a federal interdepartmental committee. Suggestions for modifications come from both the public and private sectors. Interested parties must submit proposals for modification prior to a scheduled meeting. Final decision on revisions are made through a clearance process within the Department of Health and Human Services, in which actually that particular meeting for the maintenance committee is actually happening today, where the providers and other people in the medical community are submitting their ICD-10 and PCS code recommendations to update for the next fiscal year 23. Okay, so I just wanted to kind of give a little bit of information about coding. So what is the difference between inpatient and outpatient coding? And here is a small overview of the basic differences between the two medical coding types. So the diagnosis for SDOH category can't be used as a primary reason for an inpatient admission, because of the reimbursement of diagnosis-related groups is only limited to the 740 DRG category. That has been considered as one of the 25 NDC major diagnostic categories. If the codes are used, it would be considered ungroupable and not receive any reimbursement from Medicare or a third-party payer should they be used as a primary diagnosis for an inpatient stay. CPT codes are different than ICD-10 codes, which identify diagnosis of medical conditions and not what treatment was provided. These codes are also necessary for billing insurance companies as they explain why the treatment described by the CPT code was provided. You can learn more in our guide to ICD-10 codes, while the ICD-10 provides information about the medical need for service or procedures provided. And I am going to pass it back to, okay, so this was part of the revolutionary change starting in fiscal year 2022. ICD-10 permits SDOH to be coded as primary diagnosis for outpatient visits. And so the following ICD-10 coding guidelines for social determinants of health basically is just in a nutshell, persons with potential health hazards related to socio-economical and psychosocial circumstances. Code assignment may be based on medical record documentation from clinicians involved in the care of the patient who are not the patient's provider, since this information represents social information rather than medical diagnosis. So just for example, coding professionals may utilize documentation of social information from social workers, community health workers, case managers, or nurses if their documentation is included in the official record. Okay, and here are examples of the SDOH diagnoses. This is not an all-inclusive list. This is just some under the varying categories of economic stability, education, social and community context, health and healthcare, neighborhood and built environment. And also, I included a slide in here to kind of show, give an example of how that would, the SDOH codes would be looked up in the lexicon in CPRS. So to search for the appropriate SDOH ICD-10 CM code in CPRS lexicon, you only need to use certain keywords to bring up what you need, such as the word illiteracy to find code Z55.0 that you see in the example from CPRS. And so in that case, if you wanted to look up extreme poverty, you would enter in poverty for Z59.5. For low income, you can just enter the term low income for Z59.6. And unemployment would be, you just type in unemployment, Z56.0 in the lexicon to look those up. So the social SDOH impact on medical decision-making, we have assessed the patient's SDOH. We have documented the patient's SDOH. We now have to tie the SDOH diagnosis to the status of the patient's current health condition. Okay, and what I have here is just a little excerpt from the evaluation and management coding guidelines to give a example scenario linking the SDOH diagnosis code to the appropriate E&M level. So basically, the patient comes in for like a follow-up laboratory test after a review of laboratory testing and discussion with the patient. The provider confirms that the patient now has hyperlipidemia in addition to hypertension. The provider states that the patient should start with a dietary modification and exercise to lower their cholesterol. If their condition does not improve, a statin or another cholesterol-lowering medication may be needed. An appropriate review of symptoms, past history, family history, and social history, and examination are performed relevant to the visit and the diagnosis. And the patient also indicates that they recently lost their job and they are the sole wage earner for their family since losing their job, and have needed to start using food pantries, also eating more fast food. The provider refers the patient to nutrition counseling and the social worker. So based on the AMA table for medical decision-making, the NDM elements, this visit coded shown in the table above would be at a office visit level, outpatient office visit level of 99214. Okay, and I'm going to hand it over to Dr. Cohen.
Great, thank you so much, Maria. So now, using the same scenario that Maria just laid out, this is one potential way that a clinician could document the assessment and plan. Hyperlipidemia, discuss starting with dietary modification and exercise, and referral sent to a dietitian. Repeat labs in 3 months. If no adequate improvement, may consider a statin. Hypertension's well controlled, continue the current medications. And then also noting financial hardship and food insecurity, and that the patient was referred to social work. So Maria, if a clinician provided this documentation, how do you think a coder would code this note?
Basically, with this portion of the assessment and plan, the coder would code the hyperlipidemia as the primary reason for the visit, and the social determinant for the financial hardship and food insecurity would be coded, but it would not be the primary reason for the visit because it is not linked properly.
Okay, thank you. And then we're gonna
Dr. Cohen, you are muted.
I'm so sorry. Thank you. How about taking another approach where I've now said that it's hyperlipidemia complicated by food insecurity. So I'm specifically linking the two. Again, saying we discussed starting with dietary modification and exercise, noting that recent job loss and resulting food insecurity are making it difficult to afford healthful foods and are complicating dietary changes. Noting here that I referred to social work, both for financial and food assistance resources, also referred to a dietitian, and for heart healthy dietary counseling. Again, it's kind of explicitly saying in the context of limited budget and food pantry use, we'll still follow up with repeat labs in 3 months, and if not adequate improvement, we may consider a statin. I recognize clinically this is a simplification, but just kind of thinking in the context of this example, what we might document. And then again, noting that hypertension is well controlled and that will continue the current medications. So Maria, how, if at all, would this change things for a coder, and what primary diagnosis code would this assessment and plan support?
Well, it is stating that the food insecurity is what's complicating the patient's hyperlipidemia and everything. So based on that, the coder would put the food insecurity as the primary reason, and that it would be coded as the primary.
Okay, so so for this one, even though I said in this example, it's hyperlipidemia complicated by food insecurity, is that adequate for food insecurity to be the primary diagnosis code? Or in this example, would hyperlipidemia still be the primary and then food insecurity kind of embedded underneath that?
Well, I mean, it is still kind of ambiguous, and you could possibly receive a query from the coder about the food insecurity complicating the hyperlipidemia. So if it was really showing that it was actually, exacerbating or something like that, then the food insecurity could possibly be the primary.
Okay, got it. So connecting the dots better in this example, but it's still a little bit ambiguous. So maybe we could do a bit better.
Right. Yes, ma'am.
Okay. So let's.
Dr. Cohen, you're muted again.
I'm so sorry. Somehow I think when I'm advancing the slide with the space bar, it seems to be muting me. I apologize. Thank you for that heads up. So let's try one more time with this assessment and plan documentation. So now I start with food insecurity and say the recent job loss resulting in food insecurity is making it difficult for the patient to afford healthful foods, and that's exacerbating the hyperlipidemia. Again, note that I referred to social work and also referred to a dietitian. And then I still have here the hyperlipidemia and the hypertension below that and discuss the medical decision-making and plan for each of those conditions as well. So how, if at all, would this change things in terms of how a coder would code this?
Now it is much clearer in this part of the scenario, showing that the hyperlipidemia is being exacerbated by the patient's food insecurity, recent job loss, and makes it a lot clearer for the coder to say that this is the primary reason why the patient is here for their visit.
Okay, great, thank you. And then I know this has certainly been instructive for me as we've been preparing for this presentation and thinking about how I do my documentation for my notes. So one quick question that I know came up when we were kind of all prepping this session was that if a veteran is service connected for hyperlipidemia, for example, does hyperlipidemia need to be the primary diagnosis code for the visit in order for the visit to be covered as a service-connected related encounter?
No, it does not have to be the primary reason for the visit to fall under their service connection. Actually, what has to happen with those service-connected diagnoses is it has to show that it is being treated or managed or evaluated in some type of way. Some type of treatment has been focused towards the service-connected diagnosis, and it could be a secondary diagnosis or a primary diagnosis, as long as the documentation is showing treatment.
Okay, great. So if based on the visit itself, we feel like a social determinant like food insecurity is actually kind of the primary diagnosis code and the primary driver of what else is being discussed, in this case, the hyperlipidemia and, quite likely exacerbating the hypertension as well, we can document such that the food insecurity will be, or the social determinant will be coded as the primary diagnosis code. But then if in the visit we're also discussing a service-connected condition, as long as we're documenting that, we can still code that as a service-connected related encounter.
Yes.
Okay, perfect. I know that had come up as a question among us, and I'm guessing we're probably not the only ones who have had the question, so thank you. So then one last iteration, at least for now, just recognizing that there's limited time for documentation. We had kind of talked about if it's possible to have a version of an assessment and plan with slightly less verbiage that would still meet the necessary documentation criteria. So here I again kind of have food insecurity as the initial diagnosis, and then hyperlipidemia, and then hypertension, but I've condensed my documentation a bit. So Maria, would this still meet the necessary documentation criteria for food insecurity to be considered the primary diagnosis code?
Yes, it would. Even though it has been abbreviated a little bit from the previous documentation, you're still stating that the food insecurity is the cause of the exacerbation to the hyperlipidemia.
Okay, great. And then are you able to just kind of provide any guidance for those of us who may be doing this kind of about, as a coder, what is kind of the minimum documentation and the minimum elements that you need to see in an assessment and plan to be able to support the diagnosis codes and encounter documentation?
Well, basically what the minimum requirements that we would need to see in the assessment and plan is just basically showing the diagnoses where they're being managed, evaluated, assessed, and treated by the provider, and showing what type of work or what type of treatment or any type of referrals that's going on with those diagnoses. Even something also as simple as on the hypertension, stating that they're well controlled and they're still going to take the current medication that you have prescribed for them. We just need to see, what type of work is being done on each diagnosis that you're managing or treating at that time.
Okay, great. Thank you. That's incredibly helpful. And then Dr. Hooshyar, circling back to you, now that we've talked about the various ways to document this encounter, what are the actual implications of having food insecurity as the primary diagnosis code versus hyperlipidemia as the primary diagnosis code? And, I know you alluded to this before, but now that we really kind of have an additional clinical encounter to latch onto, I'm just thinking maybe we can have a little bit more of a discussion of, in the context of this clinical encounter, and particularly in an outpatient setting, like, why does all of this matter?
Thank you for bringing that up again. It matters because it promotes the voice of the patient, meaning the real reason that the patient sought help, which then leads to a more accurate diagnosis, which then leads to a more appropriate treatments at all levels of care, from the individual patient-clinician interaction to process improvements, whether at the clinic or facility or policy level. So let us all imagine a healthcare world where, for example, we saw food as medicine. And I know, Alicia, you have experience with food gardens and providing canteen vouchers to veterans with food insecurity. And I'm not discounting these interventions, but I aspire, and I think we all aspire, to be able to do more than that. And just one example is when I was searching for the cost of treating high cholesterol, the articles I found discuss the medication cost for treating hyperlipidemia and not the cost associated, for example, food interventions. But if we had consistent vital statistics from actual clinical encounters that a leading reason for hyperlipidemia is inability to purchase healthy food, I have confidence in all of us, and hence our healthcare system, that we would implement processes in our healthcare delivery that would provide provision of healthy food as treatment as equally as we are currently doing with provision, for example, of medications. And we collectively now have this ability by ICD allowing social determinants of health to be coded as a primary diagnosis for outpatient visits, which goes back to one of your original slides that shows the impacts of social determinants of health on a person's well-being. I don't know if the two of you all would like to add on to that, but I did have a couple of other points that this discussion brought up to my mind, if we can discuss those too.
I think that was an excellent summary, and I'd love to hear those other points that came up as well.
Thank you. And so I just need to reemphasize what Alicia and Maria were doing, that having good clinical documentation does not mean one needs to write War and Peace. And so a lot of physicians, clinicians often think, oh no, the coders are coming after me, so to speak, and I need to talk to them as if the English teacher is coming from a ninth grade to tell me that I'm not writing enough. It's not writing enough, but rather writing in a way that the ICD guidelines will support what we're actually trying to say that we are treating. And the best way actually to have those conversations is great that everybody's here nationally, but to have them at the facility level for the coders, clinical documentation improvement specialists to sit down with the clinicians at their medical facilities to have this discussion. Everybody's on the same page. And then the other thing, Maria, you had alluded to this, but if you could give like an example, you had said something to the fact that information in the clinical charts, for example, by a social worker or a non-physician, as an example, can be utilized by coders to pick up social determinants of health as a primary diagnosis. So how could that be done? Like, let's say, could Alicia have said, like she had finished her, she'd seen the patient for the day, and she hadn't had the opportunity to look at everybody's notes that had been written by other clinicians, or maybe the patient went and saw a social worker after she saw Alicia, and a social worker had then said, oh, the patient has just recently lost their job and they can't afford healthy food options. Can Alicia then write in her note, like, please see notes from social worker on whatever date to support the diagnosis of a social determinant of health being the primary diagnosis?
Yes. Part of the guidelines has established that we can review other documentation from those type of providers as well to use the social determinants as a primary diagnosis. It still would have to be, determined by the physician that, this is linked to the reason why their diagnosis has been exacerbated or something like that. But we can take that information from the other providers.
Great. So what I'm translating in my mind, please correct me if I'm wrong, is that the physician does not need to be the primary person getting that information from the patient, because they could have gotten it from a clinical note written by another clinician, but the physician will need to write in their note that the reason for the visit was a social determinant of health, if that is the case, to be the reason. Is that correct?
Yes. Yes, it is.
Thank you. And I think by physician, you're meaning like the treating provider for that patient, for that encounter. So like nurse practitioners and physician assistants and other medical clinicians. Excellent. And then the other thing is, I think it is huge what Maria has showed us, in addition to educating us about the revolutionary change in ICD coding, that lexicon in CPRS. So coders out there, please, this is a gem to take to your fellow colleagues at your facilities. I know myself, before prepping for this, whenever I was trying to find out like what is the code, I would go to Google, but CPRS, 3 points for CPRS, actually has that quite easily attainable, and you don't need to be very specific. Actually, Maria gave us some specific verbiage, but you can actually write some non-specific verbiage, and CPRS is able to bring that up. So thank you for that enlightenment, Maria.
You're welcome.
All right, back to you.
And now I think, Dina, if you can pass the baton back my way, I'm looking at the time, so I want to make sure that we have time for questions. I'm just going to very briefly, here, let me go ahead now. And now that we've talked about how to document unmet social needs, I just want to talk very briefly about how to identify these needs in the first place. So the VA currently screens systematically for food insecurity, housing instability, and intimate partner violence. And within VA, we're incredibly lucky that we have a number of robust interventions to address these needs. But how can, the VA does not have a system for systematically screening for social risks more broadly. So how can we better identify social risks and social needs systematically and connect veterans with existing VA and community resources? So I'm going to give a very whirlwind intro to ACORN, and then there's additional information on the final slides if folks haven't want to find out more about it, or also I and the ACORN team are happy to talk more about this offline. So ACORN aims to identify and address unmet social needs among all veterans to improve health outcomes and promote health equity. ACORN, which stands for Assessing Circumstances and Offering Resources for Needs, is a QI initiative funded by the Office of Health Equity and implemented in partnership with the National Social Work Program. ACORN systematically screens veterans for social needs within the 10 domains listed here, and provides clinical care teams with real-time information about veterans' needs, and then seeks to address identified needs by offering veterans relevant resources and referrals to VA and community services. So on the left-hand side is just an example of some of our screening questions, and then on the right are examples of some of the resource guides, geographically tailored resource guides that our team has developed that we're able to provide to veterans at the point of care. And so ACORN can be administered either via e-tablet or paper-based screening. There's also a CPRS template that can be made available so that staff can administer the ACORN screener directly within CPRS. So far, since 2018, ACORN has been implemented and evaluated in several VA clinical settings, including general primary care, women's health, and mental health, as well as a number of ongoing pilots, which are listed here. And I'm going to stop there for now, but again, we have contact information at the end. We're happy to provide more information about this if it's of interest. But now I'm going to turn things back over to Dr. Hooshyar.
Thank you. So our parting thoughts is that we are all in this revolutionary moment together, meaning we need to unlearn what we've been taught for around 300 years, that social determinants of health can be documented and coded as the primary diagnosis for outpatient visits. These changes will require administrators to build processes that support the capturing of the impact of social determinants of health on patients' health and care, and clinicians and coders at the facility level will need to face this brave new world together. Researchers will need to analyze the impact of capturing social determinants of health on healthcare and patients' health, utilizing this new ICD code ruling, and policymakers will need to utilize research findings to address social determinants of health's impact on healthcare and patients' health. Just so like in 1762, when the first attempt to classify diseases systematically occurred, our time is also undergoing a seismic change. The difference is now we are open to the idea that it is important to systematically capture social determinants of health, such as nutrition and housing, in the quote medical setting of healthcare, not just in the social services setting of healthcare. And as we're coming to the end of our time together, I would like to acknowledge Maria. She not only did not dismiss my complaints about ICD, but remembered them so that even after I'm no longer a physician advisor role, when the ICD changed its rules, she sent me an email entitled "The Who's Greatest ICD Hits for 2022. This time, I knew she was making fun of me for not knowing the relationship between the WHO and ICD. But despite being a great mentor, she has not yet convinced me that clinical documentation and coding are fun, but she has shown me their power. To improve the lives of patients we treat, clinical documentation and coding are the backbone of this change. I would also like to thank Alicia, who has been an incredible collaborator, whose genuine concern about the patients she treats clearly comes out through in her work. Alicia, Maria, and I would also like to thank Shana, Heidi, and VA Office of Health Equity for their presentation assistance. Without them, we wouldn't be able to spread the word of this revolutionary change in ICD coding. We would also like to thank you all in the audience for your interest and attention, and we hope we've educated and motivated you all to incorporate this revolutionary change in the coding in your work. Thank you.
Thank you so much. And with that, let's move on. We've got a few minutes. Let's see if we can get through a couple of questions here. The first question we have, can you clarify for outpatient settings, the reimbursement is based on negotiated rates for CPT HCPCS codes, not the ICD-10 CM codes. The ICD codes are only used to substantiate need for the procedures, etc., correct? How do you expect this to affect completeness of diagnosis, coding, documentation, in capitation type environments?
I love it, and that's why Maria's here. And I told her she's going to get 5,000 questions, and Alicia and I are not going to get any. So, Maria, all yours.
Well, based on my understanding of capitation is not really a capitation type environment is not really about so much the diagnosis codes and things of that nature. It's more about, the accumulative amount of members that you have per month, and the third party payers is paying based on those members. Now, however, if these specific plans have certain types of carve outs or certain types of other things that's going on with those types of capitation plans where they can accept certain diagnoses linking medical necessity with those procedures, then those things would have to probably more be worked out in the appeals process. And when we're using the social determinants of health, it will be more to identify why a patient is here for a certain type of office visit versus, like, say, if they were getting some type of surgical procedure, the social determinant would not be the primary factor or the primary driver for showing medical necessity for that surgical procedure. And I hope that answered the question.
Great, thank you. The next question that I have here, for time-based EM coding and billing, are there any concerns with using the Z codes as the primary diagnosis?
Yes, there is concern, like when we do file these claims to PCE and it goes over to CPAC for billing. For the VA, they do have issues with the Z codes. However, you will have to give an explanation and state that it was based on medical necessity that we use the social determinant as the primary diagnosis code.
Great, thank you. The next question here. Are these conceptualized as social determinants of health in medical contexts as well?
Hey, Alicia, would you like to take that question?
Yeah, I guess I might need a little bit of clarification about what these is referring to. I don't know if the speaker or if the person who wrote it either can clarify in the chat, or also happy to try to answer that after the fact as well, after the session as well.
Okay, I'm not seeing a comment coming in yet. We'll move on to the next question and see if we get another response in here. The next question here, is it possible to include another column that contains environmental factors, such as access to potable water, proximity to sources of air pollution, experience with extreme weather events?
As far as the coding is concerned, yes, I mean, those are there. That list that I included in my slide was not an all-inclusive list for the diagnosis codes. So yes, but those would be additional FDOH codes that can be used.
Great, thank you. We are at the top of the hour here, so we do need to wrap things up. We do have a couple pending questions out here. I am going to get those sent over to the panelists so that they do have access to those questions and can respond offline after the session. I just want to give our presenters a moment if any of you have any closing remarks you'd like to make before we close the session out.
Again, thank you, and this has been great interest from this engaged audience, and really enjoyed everybody's collaboration. Alicia, Maria, any parting thoughts?
Yes, thank you to everybody, and I have really enjoyed working with Dr. Cohen and Dr. Hooshyar on this, and to get the word out on the coding and documentation piece.
I also just want to add my thanks both to this amazing team and to all of you for joining us. And I also want to quickly thank Kathleen Mitchell, the Acorn Project Coordinator, for their assistance with the slide design for this presentation. The slides are far more readable than it would have been if without their assistance. So thank you.
Most definitely. Thank you, Kathleen. Thank you, everybody.
Thank you, everyone. For the audience, when I close the meeting out, you will be prompted with a feedback form. We would appreciate if you wait for just a minute or two and fill out that form. Thank you, everyone, for joining us today, and we look forward to seeing you at a future HSR&D Cyber Seminar. Thank you, everyone.